Welcome to the 2023 CGA-IGC podcast series, brought to you by the CGA-IGC Education Committee. Each episode aims to bring you an in-depth discussion related to emerging data, clinical challenges, and unique perspectives in the world of hereditary GI cancers. Before we start, we'd like to remind you that the content of this podcast is not intended to replace professional medical advice, diagnosis, or treatment, and the content reflects expert opinion at the time of recording. Keep listening to find out more about this episode's host, guest, and featured topic.
My name is Josie Baker, and I'm a genetic counselor at The Ohio State University's Comprehensive Cancer Center, and I will be your host today. During today's podcast, I have the distinct honor in introducing our expert guest, Rachael Lopez, a dietitian from the National Institutes of Health. Our focus will be on hereditary diffuse gastric cancer and the impact and considerations for a prophylactic gastrectomy. Our listeners will be familiar with hereditary diffuse gastric cancer as being a highly penetrant cancer predisposition syndrome, associated mainly with diffuse gastric cancer and lobular breast cancer. Rachael, thank you for being with us today. So let's go ahead and jump right in. At the NIH, you specialize in working with surgical oncology. Would you tell us a little about your role and specifically your work with families and individuals with hereditary diffuse gastric cancer?
Yes, thank you so much for having me today. I work with the surgical oncology team at the National Institutes of Health, led by Dr. Jeremy Davis, who specializes in the treatment of hereditary diffuse gastric cancer. My job title is a clinical research dietitian, but a description of what I do is to help people get the right nutrition when it is hard to eat, as is often the case for those with gastric cancer, or when they are missing part of their gastrointestinal tract, such as after a total gastrectomy. I have the privilege of working with people every day who are either preparing for or have already had a prophylactic total gastrectomy. I begin meeting with individuals who are considering or preparing for total gastrectomy as soon as possible to provide education and counseling on how best to prepare for surgery and about the long-term diet and lifestyle changes and health concerns post-op. Individuals really need this information to make an informed decision about surgery. My pre-op counseling sessions include addressing any GI symptoms that make it hard to eat before surgery, correcting any vitamin or mineral deficiencies, counseling individuals on diet and lifestyle changes to help them reach a healthy pre-op weight, and modifying behaviors such as practicing chewing thoroughly, which are crucial for both digestion and nutrient absorption after the stomach is removed. For those who undergo total gastrectomy, I meet with them for ongoing counseling and education during their admission for surgery, very frequently throughout their first year post-op, and then at least annually thereafter, because nutrition issues arise weeks, months, and even years after total gastrectomy. Also, even though individuals have the same surgery, and when it's done here by the same surgeon here at the NIH Clinical Center, their experiences, challenges, and specific nutrition needs vary significantly post-op, which requires frequent, long-term, and individualized nutrition consultation to meet each person's needs.
Thank you for sharing more about the important role you play in this journey that many people with hereditary diffuse gastric cancer face. What other providers are typically involved with this process of following the population?
Our program at the NIH Clinical Center has a strong interdisciplinary component to support individuals and their families navigate the diagnosis, management options, and follow-up care. In addition to the surgeon, the physician assistant, and/or the nurse practitioner, the team includes gastroenterologists, a genetic counselor, dietitian, pharmacist, social worker, mental health specialists, case managers, patient care coordinators, among other team members. Total gastrectomy really impacts the entire body, physically, mentally, and emotionally. So it takes a specialized team to address the unique needs for those with hereditary diffuse gastric cancer.
So following up on the discussion about the impact on the entire body, can you tell us a little bit more about the physical impacts that someone can face after a total gastrectomy?
Yes, good question. Because there are several physical impacts, including weight changes, the risk of loss of bone density, changes to physical fitness, among others. And many of these physical impacts really result from the unintentional weight loss, which is an expected effect after total gastrectomy, because this surgery makes it both harder to eat and harder to absorb nutrients. In our analysis of weight changes, people who are in a healthy BMI range before surgery lose an average of 15% of their body weight by 6 to 12 months post-op. People whose BMI is in the obese range before surgery lose an average of 30 to 35% of their pre-op body weight. This unintentional weight loss includes loss of lean body mass, meaning muscle mass and bone density. Loss of muscle mass not only results in changes to physical appearance and body image, but also to strength, work capacity, and fitness. With time from surgery, people can regain muscle mass slowly, but it's much harder to do so after a total gastrectomy and really requires vigilant attention to both nutrition and appropriate exercise. The loss of bone mineral density is a well-documented risk after gastrectomy that results from the malabsorption of specific micronutrients, including calcium, vitamin D, and vitamin K, as well as the decreased mechanical loading with the weight loss. We recently published a paper on bone health changes after prophylactic total gastrectomy, noting that average bone mineral density decreased in all patients at the 12-month post-op time point. We examined adherence to the recommended micronutrient supplements as part of this analysis, and those supplements include calcium citrate and a specially formulated bariatric multivitamin. And we found that non-adherence to supplements was associated with a greater loss of bone mineral density. Additional physical impacts can also result from micronutrient deficiencies, such as hair loss, changes to the nails and/or skin, tooth decay, taste changes, fatigue, neuropathy, among other adverse consequences. Fortunately, nutrition interventions do help mitigate these physical impacts, namely education on diet modification to optimize absorption and prevent post-gastrectomy symptoms, education on how to prevent and treat micronutrient deficiencies by taking the necessary micronutrient supplements, and education on strategies to optimize bone health via weight-bearing and weight resistance exercise lifelong.
Following the physical impacts, can you also talk more about the psychological implications these individuals face as well?
I really appreciate this question because the psychosocial impact is as important as the physical impact, but often overlooked during the preoperative counseling and even in the literature on the risks related to total gastrectomy. In my experience, every single patient has had to change their diet and lifestyle after total gastrectomy to address the physical impacts we discussed, such as the unintentional weight loss, and to ensure adequate hydration, prevent the adverse sequelae from micronutrient deficiencies, and to manage GI symptoms. As a result, many people express grief about the loss of their stomach, because without hunger cues, eating is often perceived as work rather than pleasure. Needing to have a regimented meal schedule with specific diet restrictions means eating changes from a social and pleasurable experience to more of a calculated, monotonous, and often isolating process to meet nutrition needs. The risk of post-gastrectomy symptoms such as nausea or dumping syndrome often causes stress and anxiety around eating, especially in social situations. Additional psychosocial implications include changes to body image that results from the significant unintentional weight loss. Not everyone benefits from the weight loss after this surgery, especially those who are lean pre-op or those who have had a history of body dysmorphia or disordered eating. Pre-op evaluation should screen for this history to allow treatment before surgery, since rapid weight loss can trigger disordered eating habits for those with a history. Additional stressors can include if an individual needs to change jobs or even careers to accommodate the need to eat and drink frequently throughout the day, and changes to identity that go along with the change in job and/or the change in eating patterns and weight loss after gastrectomy. Food and eating are central to so many aspects of our daily life, including social interactions with peers, colleagues, and family, at parties and celebrations, and in family and cultural traditions. So changing how, when, and what to eat really impacts all areas of individuals' lives.
How do the differences in life stages of an individual impact their decision for surgery?
This is another great question. Factors that individuals in their teens, 20s, and 30s need to consider are often different than those for adults in midlife and beyond. For example, our research and experience with young, healthy individuals considering this surgery has shown they often report stress and anxiety about the post-gastrectomy diet and lifestyle changes, such as needing to be attentive to nutrition labels to make sure foods won't cause dumping syndrome, and needing to plan meals and snacks rather than being spontaneous with what and when they eat. In addition, this age group doesn't usually need to worry about osteoporosis or muscle loss or taking vitamin supplements. So the physical changes and long-term concerns after total gastrectomy can feel especially daunting for younger individuals faced with the decision to have surgery. In addition, individuals who are still in school or early in their career often consider whether to first get established in their career before undergoing surgery. But regardless of life stage, not all jobs are conducive to eating and drinking throughout the day. Unfortunately, we have had patients of all ages who needed to change jobs or even careers to accommodate their need to eat and drink frequently throughout the day. Women of childbearing age often consider family planning when deciding if and or when to have surgery. Women can have healthy pregnancies after total gastrectomy, but they require additional diet modification and micronutrient supplementation, along with close monitoring due to the nutritional demands of pregnancy, meaning they need to be able to eat enough to support healthy pregnancy weight gain and ensuring adequate micronutrient stores to support a healthy pregnancy and to prevent deficiencies, which would adversely impact both mother and baby. Older adults may have a more flexible schedule to allow them to eat, drink, and rest whenever needed, especially if they're not caring for young children and or if they are retired. However, they may have other chronic diseases which impact their fitness for surgery, their recovery from surgery, among other concerns. For example, individuals with arthritis may not be able to exercise as comfortably to prepare for surgery or to maintain their muscle mass and bone density after surgery. Another example would be individuals who have low bone density before surgery, which is of concern due to the even higher risk of bone density loss after total gastrectomy. An important point here is that there are different considerations for individuals at different life stages, but individuals in every life stage face challenges after a total gastrectomy.
Thank you for addressing the challenges these individuals face. This highlights the very important aspects that providers should be aware of when discussing this information with the hereditary diffuse gastric cancer community.
That is such a good point. So much about this is not necessarily intuitive. That is why I spend so much time educating patients well before surgery.
Moving forward, how do you best support these individuals during the process?
Yeah, so I do start with the pre-op nutrition consultation well before surgery to best prepare people for the diet and lifestyle changes after total gastrectomy. That may include optimizing their nutrition status before surgery, and it also includes preparing them for the lifelong diet and lifestyle changes, and then supporting each individual in their post-op recovery, especially during the first year post-op, which is a challenging time for everyone as their body adjusts to digesting and absorbing nutrition without a stomach. I often remind people that recovery from a total gastrectomy is a marathon, not a sprint. Many other surgeries have a max recovery time of 3 months, but for total gastrectomy, 3 months is still the starting point in the recovery process. For most people who have a total gastrectomy, full recovery to the point of maintaining weight without having to micromanage their diet and nutrition takes about 1 year. What I mean by this is that it is a full year before most individuals feel as if they reach their new, stable, post-gastrectomy normal, when they are no longer spending all their mental energy reminding themselves to eat, making sure they are eating enough, reading labels carefully to make sure they are choosing foods that won't cause dumping syndrome, and remembering to take all of the necessary vitamins every day. Our clinical research protocol here at the NIH Clinical Center includes follow-up with me, the dietitian, at very frequent intervals the first year and at least annually thereafter, with additional follow-up as needed between those required post-op visits. I collaborate with my other team members to address concerns that impact nutrition, such as engaging with a mental health specialist to treat depression or anxiety, which impact motivation to eat, drink, and take the required vitamins. I collaborate with the pharmacist near daily, if not multiple times daily, about which medications and at what doses are needed for management of GI symptoms or for IV infusions to address micronutrient deficiencies, such as iron deficiency. The frequent interdisciplinary follow-up allows us to address problems as they arise to prevent long-term health concerns.
In your experience, Rachel, what is the most challenging aspect of patient care in this population?
I really enjoy working with this population, but I admit it's very challenging when patients are given medical advice that does not consider the changes in absorption and the subsequent unique health and nutrition needs after a total gastrectomy. For example, preventing dumping syndrome by adhering to the post-gastrectomy guidelines is absolutely essential to promote both comfort with oral intake and optimal absorption, and to avoid dehydration, rapid weight loss, food aversions, and even the fear of eating. However, it is not uncommon for a patient who is losing weight too quickly to be told to ignore the post-gastrectomy diet restrictions and to drink one of the popular oral nutrition supplements or to just eat ice cream. While those recommendations may help someone with a full GI tract gain weight, those items are very high in added sugars, which causes early dumping syndrome after a total gastrectomy, and that results in abdominal cramping and diarrhea, which subsequently exacerbates the weight loss, dehydration, and the fear of eating after a total gastrectomy. Another example would be telling an individual who's suffering from severe fatigue and has a ferritin level of 6 when the reference range is from 20 to 150, but that patient has a normal hemoglobin, if a provider tells them that they aren't anemic, so no treatment is needed, when in fact they are severely iron deficient and need an iron infusion to correct the problem because they don't absorb iron well after a total gastrectomy. Total gastrectomy really results in unique health and nutrition needs and considerations, so finding the right team with the right experience is crucial for this population. Our team at the NIH Clinical Center works to collaborate with outside providers. We do that via direct correspondence from provider to provider, as well as sharing our publications and presentations, and by publishing our patient education materials for hereditary diffuse gastric cancer online, which you can find at ccr.cancer.gov.
This has been incredibly insightful. Do you have any main takeaways you would like the audience to have as we wrap up?
Yes, absolutely. I want to emphasize that while a prophylactic total gastrectomy is a prophylactic surgery, it's not without risks. It's really hard to eat for at least a period after a total gastrectomy, and it's hard to absorb specific nutrients, which creates a nutritionally high-risk population with lifelong nutrition concerns that impact quality of life and overall health. So if I had to give just 3 main takeaway points for the audience, they would be: 1, to ensure individuals with hereditary diffuse gastric cancer have an experienced interdisciplinary team, including a dietitian who has experience with total gastrectomy, to help navigate the diagnosis, management options, and lifelong follow-up care. 2, to prioritize pre-op education on diet and lifestyle changes, as well as long-term health concerns, to inform decision-making and to ensure understanding before surgery. This education is really crucial for individuals to be able to plan accordingly, including career planning, family planning, ensuring access to appropriate health care, among other significant considerations. And 3, to provide long-term follow-up to monitor and address the lifelong health and nutrition needs for this population that arise weeks, months, and even years post-op. To summarize, We need to recognize that a total gastrectomy changes an individual's health and nutrition needs for the rest of their life. So we need to ensure that they have the knowledge, tools, and resources to lead a long, healthy life.
At this time, we will conclude this podcast. Once again, thank you, Rachael, for joining us for an episode of the 2023 CGA-IGC podcast series. Stay tuned for the next episode to come. Thank you to all of our listeners.